back. Today I'm here with Dr. Michael Wilson, who
Hi.
is both a good friend and colleague of mine. He is a doctor of emergency medicine and assistant professor of the Department of Emergency Medicine and the psychiatry director at the Department of Emergency Medicine Research Program in Little Rock, Arkansas. Is that correct?
That's so true. Hi, everyone.
And he also has a PhD in psychology from the University of Illinois, which we both attended. So today I wanted to talk with Dr. Wilson because he's also a specialist in assessing suicide risk. And I wanted him to talk with us about how one assesses suicide risk, what happens when a patient that is suicidal ends up going to an emergency room, and a little bit more about some of the research that you're doing as well.
So, hi to everyone, and in case you don't know, I've actually known your instructor, Dr. Dorian, since graduate school, when we were both graduate students together, but we're not allowed to tell any stories about that, so we're going to stay just in 2018.
Yes.
So as she said, I am an emergency department physician. If you send one of your patients to the emergency department, they will see either me, if you happen to be in Little Rock right now, or they will see someone a lot like me.
Mm-hmm.
And I think it's important for you guys to know what will happen to those patients once you send them to the emergency department. I know sometimes from the outside it kind of seems like a big black box,
Mm-hmm.
and not really sure what's going on inside. So some quick fun facts. Emergency departments are incredibly overburdened.
Mm-hmm.
They're incredibly overburdened and they're incredibly under-resourced, and that's true of almost every emergency department I've ever worked in.
Mm-hmm.
Some fun facts. These are from the National Institutes of Health, the National Center for Health Statistics. In 2016, there were approximately 5,273 emergency departments in the United States,
Mm-hmm.
and there were 136.9 million visits. I just want to let that sink in for a minute. 136.9 million people came to an emergency department in 2016, and what we've seen over the 2000s is that the number of visits are just increasing almost linearly every year. So I'm not trying to get you to feel sorry for us, but you do have to realize a lot of what I'm going to say is colored by the fact that we are not a family practice clinic.
Mm-hmm.
A lot of people tend to think, hey, an emergency department is just like a family practice clinic or an internal medicine clinic, except faster. And that's really not true. One, we see a lot more patients than they do. We tend to worry more about different conditions, lethal conditions, than they do. And we tend to do it under a lot of pressure and a lot of time stress.
Yeah.
All right. I think I managed to talk about a lot of things and not answer your questions, so maybe you'll repeat that for me.
Sure. So one of the reasons people come to an emergency department may be suicidality. So I'm curious, how do you assess suicide risk?
So that's a great question. It starts out when folks come to an emergency department. The first thing that they will be asked, and this is in something in a list of 24 or so questions that a triage nurse asks them, they will be asked some variation of, do you intend to hurt yourself? And a lot will depend, a lot sort of will branch from that point if a person says yes or a person says no. And although many emergency departments do ask everyone who comes in, there are a lot of questions we have to ask. You can imagine if you're there for your chest pain or your sprained ankle, we may want to be addressing those fairly quickly. We want to address your pain, not necessarily asking, do you feel like ending your own life? However, there are some lower quality studies that suggest that up to about 8% or so of patients who come to an emergency department for another reason may have thoughts of suicide that they won't ask unless, or they won't divulge unless we ask them. So many emergency departments will ask, as part of their standard checklist, are you thinking of hurting yourself, or some variation of that. And how we ask is an interesting question. Very little research on how you screen people. But that process itself is called screening for suicide risk, and that's actually something that each of you can do in your practice, and probably should be doing in your practice when things change with your patients. You don't have to be an expert. You can take an hour course called QPR, Question, Persuade, Refer, and learn how to ask people if they are thinking of ending their own life. Some pointers. I recommend asking directly. Don't say, well, have you had thoughts of, I don't know, ending your own life? Be direct. Have you had thoughts of killing yourself? The direct approach, we think, is the best one. So that's the screening process, and that will happen at triage, but again, can happen in a therapist's office as well.
That's interesting that you really mentioned the direct approach, because I think that especially many trainees or new therapists may shy away from a direct approach to difficult questions. And one of the most difficult questions to ask, of course, is if somebody is thinking of ending their own life.
So true. We see that a lot with our emergency medicine residents. A couple of points on that. One, if someone isn't thinking of ending their own life, you're not going to put the idea in your head, in their head. The second thing to mention is that I don't think we really tap into people's experience or their pain by beating around the bush. It's important to ask directly, but sensitively and empathetically, but directly. Are you thinking of ending your own life? Have you started to make plans for how you might do this? Those are the first two questions I tend to ask.
Okay. I'm sure the situation has come for some of you in your internship perhaps, or certainly for most therapists or counselors that practice long enough, that you may need to refer a client to be hospitalized for suicidality. That's certainly been the case for myself. Can you tell us a little bit about what happens when a client gets referred for suicidality?
Sure. So the first thing that happens, we ask them that direct question. Now, we recommend in the emergency department, this is some recent work we've been doing, we recommend not asking just a single non-standardized question. We recommend asking or using a tool to help you ask about suicidal ideation. Now, what you do or how you do is still, at least in the emergency department, is a matter of open debate. But there is some evidence from Brown and colleagues, a study published a couple of years ago, that if you use a tool like the Columbia Suicide Severity Rating Scale, you will get better information about their suicidal thoughts or intentions than if you don't use a standardized instrument. So if you're not using questions that have been worked on or researched, you should probably start. Now we're jumping a little bit ahead into risk assessment. Let me go back to screening, because that's what we're really talking about. The only screener that's been studied in the emergency department, the only one I can really talk about, is the PSS-3, and that was used in the EdSafe study, which was published last year in JAMA Psychiatry. The PSS-3 is I believe it's a 3-question screener with a 4th question if the 3rd one's positive. Takes very little time.
What does PSS stand for, do you know?
Yeah, it stands for the Patient Safety Screener.
Patient Safety Screener.
Don't know why it's number 3. Maybe it's the third version they came up with, or probably the 3 questions that they have in there. There you go.
There's a good reason.
And it is a easy, quick way to screen your patients who are at risk of suicide. So that's the first thing. And I think the question probably many of these guys are having is, when should they send someone that they've screened to the emergency department? And I'll just say, there's no good answer to that. But I'm there 24 hours a day, 7 days a week. Well, to be fair, I'm not, but one of my colleagues is. We never close the emergency department, kind of like the border or your average convenience mart. We never close. And if you have a patient that you think is at risk of suicide, send them. Send them. That's the short answer. Don't think for a minute that they're going to get good coping strategies or things to help them in times of crisis. We'll talk about why emergency departments should probably start doing that, but they aren't currently. And we don't want to send a patient to the emergency department for that reason. But if you have someone that you think is at imminent risk of self-harm, send them. We will keep them safe. We will have a trained psychologist or a psychiatrist, like Dr. Dorian, although she will not come to Little Rock to work with us. Probably because she loves working with you guys in Boulder. But
because I'm coming to Colorado.
That's right.
Yes.
We will have someone see them, not only an emergency department physician or emergency department nurse, but a mental health screener or a mental health worker as well. So send them. We'll take good care of them, I promise.
Definitely. So you talked about the difference between screening and also risk assessment. What do you think increases the risk for suicidality?
Yeah. So that's a great question, and probably I think you teach about 2 or 3 courses on that, don't you?
Well, we actually have a student that is doing a dissertation about the relationship between substance abuse and suicide risk. And what she's hypothesizing in this, or sort of theorizing, is that individuals that use substances, drinking alcohol, using other substances, and may also tend to be suicidal, may be at increased risk for a suicide attempt when they are intoxicated. And sort of the common term for this is drunkicidal. So she's exploring this phenomena, and then we will hear back from her on what she's found shortly. But in terms of the research that you're familiar with in your experience, what factors do you feel increase patients' risk for suicidality, for actually attempting and completing suicide?
So it's important to know when we're talking about risk factors, it's kind of an inexact science. Okay, so you have to kind of bear that in mind. The 2003 article or white paper from the American Psychiatric Association listed some 6 or so risk factors that elevate or increase your risk of suicide. We'll talk a little bit about risk assessment in a minute, but what I take from that is that it's suicide plus something. Okay, so if you are having thoughts of suicide and you have tried suicide in the past, you are at much higher risk. If you are having thoughts of suicide and you have a mental illness, diagnosable mental illness, especially major depressive disorder, you are at much higher risk. If you are having thoughts of suicide and you have substance use disorder, you are at much higher risk. And these are people that you should have some alarm bells going off in the back of your head, just saying, hey, take this card and call me in the morning. These are folks that you should justifiably be worried about. All right. Traditional risk assessment, and we're now through screening. We've screened someone, we think they're at high risk of suicide. Dr. Dorian actually teaches on this extensively, so she's going to correct me if I get this wrong, but traditionally how psychiatrists think about this is that they will divide your 6 or so risk factors into things that elevate your risk, and then a bunch of things that seem to lower your risk of suicide. So again, these are things
buffering factors.
Exactly.
Things that support you in your life.
That's exactly right.
In your actual life, not in your death.
No, that's exactly right. We call them protective factors. And those would be things like having a spiritual belief system, having a family that cares about you, these sorts of things. Now, how you put those together, the risk factors with the protective factors, has been a really, like I said, inexact science. People have struggled with that. So in the emergency department, what we've argued in a paper that's actually going to press soon, or I should say being submitted soon, is that emergency department physicians shouldn't worry too much about how psychiatrists have done this for decades. What we argue they should do is that they should look for things that we know increase your risk and try to manage those. So if you come to the emergency department and you only have thoughts of harming yourself when you're drunk, we'll try to hook you up with some substance use disorders, or should try to hook you up with substance use counseling. If you have an untreated major depressive disorder, we'll try to start some meds for that or treat you for that. Notice, by the way, of those 2 examples I gave, hospitalization was nowhere in there. And that's because hospitalization, it turns out, isn't we think, the magic bullet.
That's interesting.
We will hospitalize a patient that comes in if they're too high risk to send home.
Yes.
And that's,
how do you determine that? How do you determine if you refer them to a substance treatment program, to some good therapy, or psychiatric care? How do you know that you can open the doors, let them go, or you need to, in essence, keep them, admit them?
It's a great question.
Yeah.
Oftentimes how it happens in the emergency department, because again, remember, I'm trying to see my portion of 137 million visits that are coming in the door, and most of them seem to come in always on my night shift, honestly. So I will not uncommonly be managing something like 20 plus patients at a time. I feel a little bit like a air traffic controller, if you will, without the batons, without the cool batons. But anyway, so oftentimes how I'll do that is I'll rely on experts like a Dr. Dorian or her colleagues in Little Rock to come give me their thoughts on what we should do. And that means, unfortunately, these patients who just come in for some help or someone to talk to sit hours in an average emergency department. And if they happen to come into an emergency department where we don't have you, or we don't have one of your colleagues,
they don't have a psychologist, psychiatrist on staff, mental health worker,
they may end up getting transferred, oftentimes in fairly degrading circumstances, to some place that can do that. So it's good to know what your local emergency department can do and what you can't do in terms of resources.
Sure, so to already have a place in mind, some psychiatric hospitals, and then giving them a call to see if they have, even beds available. That's one thing that I used to do, to call and see, do you have a bed available for this person if they are to be admitted.
Another good thing to know is that the legislation signed just this week on Capitol Hill. I always hate bringing politics into this, but the legislation signed just this week gave more money to the National Suicide Prevention Hotline. And that is a resource that you should be giving all of your patients, so that when you're not in the office, when you're not available, they have someone that they can talk to, and those counselors are trained and able to do a brief intervention over the phone.
Sure. So it's more than just saying, in case of emergency, call 911.
That's right.
This is giving them a specific number, the National Suicide Prevention number, where folks are trained to assess and then perhaps even refer if necessary.
That's right. And certainly if the National Suicide Prevention Hotline told them to come to the emergency department, we're much more concerned about that patient than someone who just came in on their own. All right, so that was a lot. Let me kind of sum up a little bit, if you don't mind, about a typical ED interaction. So a patient with suicidal thoughts will come in, they'll be screened, and we're doing some work on a national level to try and get our ED docs not to ask a single question of, hey, do you want to kill yourself? Not because that's not direct, it's actually very direct, but because those single non-standardized questions that are asked differently between providers don't help much. So we recommend using a standardized screener like the PSS-3 to follow. If that patient is identified as being at high risk, then we will have a mental health worker like Dr. Dorian do a full mental health evaluation of that patient. Those will cover things like protective factors, like risk factors. If you're doing that, the evidence would show that you do a better job of that risk assessment using a standardized tool like the Columbia.
Or the PSS.
Well, the PSS is going to be just screening.
The screening.
So if you identified a high risk and now we realize, we have to do a longer interview with you, we're going to have to ask about past and, suicide attempts and past psychiatric diagnoses, also current treatment, current substances, current circumstances. What drove you into having these thoughts today, right? And again, a standardized risk screening instrument like the Columbia is going to be a lot more helpful to you. You're going to get a lot better risk assessment than if you don't use it. But we know, unfortunately, that just relying on a risk assessment tool like the Columbia is bound to lead to lots of errors. And we should talk about that a little bit, of why I just said use it, and then I said don't depend on it. And that's a little bit counterintuitive. We should talk about that a little bit. And the reason is we don't have a magic assessment instrument that is 100% predictive. The language we like to use is sensitive and specific, right?
Yeah.
So we don't have that. And we know that if you rely only on those instruments to do a risk assessment, you're likely to make errors. You're likely to miss people. Okay? Not because you're doing anything wrong, but because the tool itself can't predict with 100% accuracy who is at high risk or who will ultimately suicide within X period of time.
So you need to use some clinical judgment, I assume.
Absolutely.
Yeah.
No, you absolutely do. And one of the biggest things that a tool like that can't capture, that you will be able to capture in an office, how well is that patient relating to you? How willing are they to engage with you? And that's not something we can put a number on a tool or even in an emergency department. I've just met the patient. So if they're sitting there like this, okay, it's pretty clear I'm probably going to end up admitting that patient because I can't engage with them. I can't be sure that they're not going to go out and attempt suicide again.
You can't see that they have something clearly to live for.
That's right.
That they've kind of turned away from life and you may be their last resort.
That's exactly right.
You may be the end of the rope for them.
That's exactly right. Another thing that tools have a hard time capturing, although they do try to ask about it, is not how lethal the attempt actually was, but how lethal did the patient think it was going to be.
Oh, okay.
So I've met patients
That's an interesting point.
that have overdosed on acetaminophen. They weren't trying to end their own life, they just didn't read the package instructions and didn't realize they weren't supposed to take half a bottle for their sprained ankle. Whereas I've had patients who come in who took 2 Tylenol at the same time, and that's because the package said to take 1 and they thought 2 would be just the lethal dose they needed. And I'm a lot more worried about the patient in that second instance than I am in the first.
So that's their subjective experience.
That's right.
That they thought taking a few Tylenol would do it, rather than somebody that just, wanted to take a bunch of their prescription medication or maybe even get high or something.
That's right.
Well, thank you. The last thing I wanted to discuss is in the DSM, there are definitely certain diagnoses that increase the likelihood for suicidality, but then there's also conditions for further study, and non-suicidal self-injury is actually a criteria here. And that's and then there's also suicidal behavior disorder. That's a condition for further study. So on page 801 of the DSM, proposed criteria that may come up in DSM 5.1, 5.2, potentially.
Here, come up, say hello.
This is my son.
Cute little guy.
Who wants to discuss with us. Is the suicidal behavior disorder. So I recommend you take a look at this. And this suggests that this will be a diagnostic criteria for study. Within the last 24 months, the individual has made a suicide attempt. And the act does not meet criteria for non-suicidal self-injury. It does not involve self-injurious behavior. The diagnosis is not applied to suicidal ideation or preparatory acts. It was not initiated during a state of delirium or confusion, and the act was not undertaken solely for political or religious objective. So this is a kind of a interesting potential diagnostic category that's proposed, and I'm curious what you would think of something like this. Do you think that suicidal behavior disorder necessitates its own, diagnosis?
Yes.
That's a great question. That's a great question. I'll just say I tend to think of the DSM a lot like I think about the TIMI score. And the TIMI score is not going to be something you guys have heard of, but The TIMI score has been developed over years by cardiologists. I love recording with Dr. Dorian. It's cute guy. Anyway, back to chest pain. So the TIMI score has been developed over years by cardiologists, and it's highly predictive, it turns out, of predicting whether someone's going to have a heart attack or not. And you don't need to know the components of the TIMI score. Just take my word for it. It's a score. It has to do with all the things you think it would be. Are you a smoker? Do you take aspirin? Is your cholesterol high? These kind of things. And it turns out once you hit the emergency department, all we really care about is, are you having EKG changes along with your chest pain?
Yeah.
The same kind of thing is true of suicidal behavior. Once you're in acute enough crisis to come to the emergency department, are you having an acute enough crisis that I can't reliably send you out because that isn't resolved? Or can I help manage those conditions while you're in the emergency department to allow for a safe discharge? Nobody wants to be hospitalized. It's time away from work. It's time away from your family. It's the stigma. It's the incredible stigma of people knowing that you were in a psychiatric hospital, right? Even in the emergency department, we treat you differently. We put you in a separate area. We give you special scrubs because we don't want you to hang yourselves with them, right? We don't want to subject you to that if we don't have to. So, that was a long answer. I'll just summarize it by saying the DSM is great. I don't pay attention to it.
Okay.
And what I really care about is how imminent is this patient's self-harm. And if you're thinking about whether to send a patient to me, that's all I care about. Do you think your patient at this time has some condition in their life that makes them at risk of harm? That's all you need. If you think that's true, you send them to me. We will take great care of them in the emergency department, I promise.
Well, thank you so much. Thank you
My
so
pleasure.
much, Dr. Wilson, for
My pleasure.
visiting and for sharing your knowledge with me and with the class. And thank you. All right, until next time.
Yeah, thank you for letting me play with your cute son, and namaste.